The following is a paid program. Advice and opinions expressed during the program are solely that of SSM Health, not WBEV or Good Karma Brands.
Well, thank you, Wally, and welcome into Taking Care of Business. I'm Justin the Ninja Wolski here with Dr. Burt Callahan. Dr. Burt, how are you doing today?
I'm doing well, Justin. Thanks for having me.
I'm always so excited when we have you on. Lately, you've been bringing me the coolest things to look at, and we're going to dive into these. Before we get into the topic of the day, for everybody who's listening, everybody who's tuning in, anybody who doesn't know who Dr. Burt Callahan is, once again, take us through who is Dr. Burt.
I'm an orthopedic surgeon that's been in Dodge County for 28 years. I'm based primarily in Waupun at the hospital there. I also have a clinic at the SSM facility here in Beaver Dam. Work with some excellent colleagues that people also know. Eric Nelson is another orthopedic surgeon in Waupun that I work with. And then Luke Lencher, Beaver Dam native, works as a PA that I work with, who's based in the Beaver Dam clinic. And then Joe Heckenkamp is based in the Waupun clinic. And I've been with those guys for quite a number of years, and they're doing orthopedics. So.
Wonderful. And, of course, we want to share with everybody so they know, because it's always good to get these numbers out there right away. If they want to get a hold of you guys in Waupun, 920-324-6802. Beaver Dam, 920-887-6650. And I think we said last time, if you call one, you get the wrong one, they could probably send you to the other one or vice versa. Or
I think they actually ring to the same. That's the
right.
That's how the secret behind the scenes.
There you go. Yeah.
So either number's fine.
But give them a call if you have any questions about anything we talk about today or in general, anything related to orthopedic surgery or orthopedic care. You guys will be the ones to reach out to. Last week, I thought, okay, this is really cool because we're talking knee replacement. Yeah. And you brought in some really cool pieces. This week, we're going to be talking about hip replacement. Now, before we get into the cool stuff you have, let's talk a little bit about hip replacement. Like, why would I even need a hip replacement?
Well, it's very similar to the knee in that the reason to do a hip replacement is pain, most likely from arthritis. So arthritis is the culprit, and arthritis again is every joint has a cartilage surface on the end of each bone, this thin white layer. If people that are hunters know that, people that eat chicken legs, the little round top that has with shiny white stuff on it. We have the same stuff. In the normal setting, our bones look that way also. And that as that cartilage wears off, that's what arthritis is. So it's like a tire going bald. And so this happens at the hip very commonly also, second most common joint that needs replaced after the knee. And once the bone's exposed, it becomes painful. And so people start limping, start having pain that affects their activities. They may wake them up at night. Those are all very common symptoms, and it just drives them to need something done, and frequently that's hip replacement.
I guess when I'm thinking arthritis, my first thought is always like hands. I always think about like my grandfather was a woodworker and did construction work and carpentry his whole life. And so you talk about feeling it in his hands. Never really think about, I guess I've never really thought about like knees, hips, and basically anywhere there's a joint, you can get arthritis, right?
Correct, yeah, definitely. And hands, it's very common. It's just people tolerate that well. We're not generally walking on our hands.
Very true.
Unless you're in the circus.
Yeah, definitely not in the circus.
But if you see people that have these kind of bumps and knobs around their fingertips, that's wear and tear arthritis.
Okay.
But mostly people put up with that very well. And there's not the kind of solution there is with the hip and the knee. But hip and knee is a problem because we're walking, we're weight bearing through them, and we're doing activities. Shoulders are a problem just because we do so much with our hands, and you need your shoulder to get your hand where you need it. So those three are the three most common joints that require replacement.
Now, when you talk about this one being a fairly common one that needs to be done, like how often are we talking, and kind of at what age range are you seeing this coming up most commonly?
Well, the age range is older people. Certainly, it's more common as we age, but it happens in younger people as well. But there's about 500,000 of them done in the U.S. every year, and that's going to probably double by 2030. The whole baby boomer population is we're all, I'm part of it. We're all breaking down and becoming frail as we age, and so that's increasing the numbers. but it's the younger people will get it in the past because of hip problems that occur at birth, and so that now we're much better at identifying that at birth and getting it treated, and so the pediatricians and the OBs are very good at picking that up, and so it's not as much of an issue as an adult as it used to be. But that used to be a common reason somebody in their 40s might need a hip replacement.
Now, when it comes to knee replacements, I generally hear about people getting like one done, and the other one tends to hold out longer, or vice versa. Is it the same with hips, or do you see a lot of double, or do you see like one now and then one maybe 5 years from now?
It's all across the board. I mean, there are people who have one that's abnormal, needs replaced, and the other one looks fine. It's not that common to have someone come in the office and both of them look terrible. It's more sequentially. It's usually one's more advanced and the other one I can see is coming.
Now, if I'm somebody who's experiencing hip pain, are there symptoms besides the pain that might be a clear indicator that there's something going on, I need to get it looked at, and that I may be heading down the road towards a replacement? And are there alternatives or steps between not doing anything and replacement?
There are not as many steps as there are with knee replacement, but one of the and the degree of pain is what drives the whole process. Interestingly, though, people that have hip arthritis classically hurt in the groin in front.
Interesting.
So people that come in and say, "Oh, my hip hurts," and they're pointing to the back part of their hip or the side, usually don't have hip arthritis. And so the hip can be a challenge in figuring out where the pain is coming from and being certain that it's coming from the hip joint. But and people vary, but the classic place where hip joint pain bothers people is right across the groin or the front of the thigh.
Now, the concept of arthritis is not new. It's been there for forever and ever, or at least for as long as I think there's been a name for it, probably.
Right.
So has this kind of joint replacement for the hip been something that's fairly new? Has it been around for a while? Like, how long have we been just popping parts out there?
Yeah, and that history, I mean, I'm biased, of course, but I find it interesting about it's really followed the development of different materials.
Okay.
And so there have been renditions of, and in the 1800s, there was a German physician who used glass. Well, that didn't work very well because it broke.
I imagine, yeah.
And then at times there was ivory was used. In the early 50s, there was a physician in the U.S. who was using metal, and that didn't work either, from the wear of the metal particles to breaking. It wasn't until the really late 50s, early 60s that a Englishman named Sir John Charnley, revered name in orthopedics, developed the modern hip replacement, borrowing from technology in the dental world. So the acrylic that's used in dental combined with metallurgy developed what is considered the modern hip replacement. And so in the early 60s, that kind of crossed the pond and started being done in the United States.
Now, when I think about the natural joint by itself, we've talked about this before, you've got the two bones that if they were just allowed to touch and wear and grind on each other, that would cause pain. And that's that arthritis feeling you feel was when that's grinding. You have that cartilage in there that works, like you said, like a tire, like a protective layer. Obviously, you're replacing some or both of those parts. Is it generally both? Like you have to replace both sides?
Correct.
Okay.
Because both sides are wearing, and the hip is shaped different than the knee. I mean, it's a different type of joint. So
right, it's like a ball socket, right?
Right.
Okay.
Ball and socket has, but you've got cartilage wear on the socket side, and you've got cartilage wear on the ball side. So you have to replace both, or the other one's going to hurt.
Okay. Now, when you were in last time, you brought in some really cool looking parts that, had I not known that they were for a knee replacement, I wouldn't have necessarily known what they were for, because they're a unique shape. They kind of look like the end of a bone, but maybe a little different. Yeah. You've got some here that are, I think, very obviously kind of bone shape, but then also not. Let's talk a little bit about what you brought in here today for us.
So on the socket side, you need generally it's a metal shell that looks a lot like this, and it's a titanium metal that has this texture on the back that bone will grow into. So most modern hip replacements currently use this type of shell where that's what touches the bone.
Okay.
And you can see there's little holes in the back where if I want to put a screw or one or two screws in, I can, to just help the security of it. I always put a screw in. I rarely need more than one. You don't have to put it in there. It's a tight fit when it goes in.
Right.
I don't see any downside to putting the screw in, and I don't want it to move at all in that period of time before the bone grows into it. So you've got to get it in the right orientation, this way, to make it function right.
Now, if I were to describe for anybody who's not able to see this, if you're not watching any of that, it's even still hard to see because it is so small. But if you imagine like opening a package of, I'm going to say ramen noodles.
Yeah.
But very, very small, fine ramen noodles, where it's very tightly, densely packed. Literally looks like little noodles of metal across the backside of this. That's what gives it the texture. And that's what you said the bone's going to kind of grow into and hold on to.
Correct.
So that's the part that's actually getting socketed into the hip bone.
Correct.
Right? But then I'm looking at the other side and incredibly smooth on the inside. And I'm seeing what looks like a compression clamp, like on this one, or a little like a washer clamp type thing. Is that for like holding the ball in? What is that for? The cartilage?
That is the locking ring for the plastic piece that goes into it.
Okay.
Now this style worked just fine.
Okay.
That locking ring was kind of a headache for me technically.
Okay.
But that has been, new technologies come out, same basic configuration, and we went to something like this.
Now this, oh wow, this is a really, really fine texture. Looks like it's been sandblasted almost.
Same shape, same titanium. It's now configured in a way that is shaped more like normal bone, and so it's felt that the bone will grow into that better than it into the ramen noodles.
And I see no loose-looking spring in here for holding the cartilage replacement in.
Correct.
So this must be held on, I'm guessing, by these little indexes around the outside?
The little ring at the base there. You can see that on this piece that snaps in there.
And that would lock it in then?
Yeah.
Okay, so I won't lock that in because I don't know if there's a way to get it out. But I see how that would go together. And then this is what the then actual ball of the hip socket that
Correct.
would rest
That,
into.
essentially, you can think of it as that takes the place of the cartilage.
Now this feels like a fairly substantial piece of material. Is this a pretty good representation of how thick the healthy cartilage would be?
Yes, pretty
Okay.
close to that. So this is the same plastic that was in the knee replacement. That you snapped in there, and it essentially is the weak link of joint replacement. Because this is what wears.
Gotcha.
And so if you can see between these two, this one is an older one that's very white.
Right.
Same plastic, but this has the yellow one. The newer one has vitamin E in it, which is supposed to make it wear more slowly.
Right, and we talked about that last time.
Right.
So yeah, that's why it's got that yellowy tint to it. And I see there's a couple different sizes here. So I'm guessing, much like knees, it's not one size fits all.
Correct. There are a ton of sizes because there are a ton of sizes of us.
Right.
And so one of the things we do when you go in there, the hip socket is hemispherical, but it's not perfectly hemispherical.
Okay.
There's cartilage in there. Some of it's worn. In some areas, there's bone spurs. And so before we put this in, we take, if you picture a cordless drill with a long center post that has a piece that looks like this, but looks more like a cheese grater.
Okay.
We stick that in there and spin it. I'm literally doing this.
Right.
And it's removing all the old cartilage, getting the bone down to healthy bone.
Right.
And is making it exactly hemispherical. So when we put this in, it is line-to-line contact all the way around.
Now we've talked before a little bit about the tools that you have to use for the trade. Are there instances where the hip is bad enough that you can't just cheese grate out enough space for, I hate to use that term, but if anybody's cringing out there, I apologize now. But where you can't, make the space for this kind of a joint?
Yes, that kind of problem is in the setting of fractures or other deformities. Sometimes there's not, in the setting that I was mentioning earlier about congenital problems where the hip is not located right, the socket won't form normally.
Okay.
And that's a specialized type of treatment. I would usually send those people to a tertiary center. Sometimes you have to have a custom cup, a different type of cup. Sometimes you have to do grafting to the socket to give it a secure bite. But the most people, the vast majority, you can use the standard instruments for that.
Now, I remember with the knees, you were saying that there was like, I forget the exact numbers, but you were like, oh, there's like 12 different varieties of this one, like 24 of that one. So there's all these combinations we can do. Are there just as many options?
There are really more. The smallest cup we have, is probably low 40, like 40 millimeters.
That's not very big.
No, I hardly ever am even close to that, and it'll go up even up into the 70s to the 80s.
Okay.
The vast majority of people that I do are 54, 56, 58, 60.
Okay.
So most people are in that more narrow range.
So we know that we've got the top part of the bone that goes into the hip joint.
Yes.
We know we've got the cartilage replacement piece that slots into that. Obviously, you said you got to do something for the bottom, the bone, the femur.
Correct.
Top of the femur.
Top of the femur, the thigh bone.
Right, because you can't just throw that bone in there. You gotta give it something.
Correct.
So, what goes there?
So you need to do something to the socket, which we just talked about, and you need a ball. It's a ball and socket joint, but the ball's got to be attached to something. So that comes into a piece like this. So that's the femoral stem.
Okay.
That the ball will go on to the end here. And so in this little model of a femur, this fits down. Now this one is not tight, which is not the way it works, but this goes down in the center. So people often ask, what about the marrow that's in there? And we just push it out. There's a space there. It's kind of like on a ribeye. If the rib is in there, then in the center is where the marrow is. Same if you look down a femur, you see that. We prepare these. These come in a lot of sizes depending on the shape and size of the femur, and then that goes down into the femur, and then you have a ball that you put on like that.
Now I'm looking at some of these inserts, and I see some of them have material shape like on it, the grittiness for, I'm guessing again, for the bone to grow into.
Correct.
But not all of them.
Correct. So the ones that have this one has the ramen noodle configuration on it, and as does this one. These are, when I started,
heavier than I expect.
Yeah, pretty. That was the implant I used when I started in the late 90s, early 2000s, uncemented, which is what most hip replacements are done with. Cemented is what Sir John Charnley started with to hold these pieces in. It's still being used in settings, and we can talk about that. But I went to this one because this is different. It's fully coated.
Right.
And if you saw it on X-ray, it doesn't look solid because it was made to be the same flexibility of bone. Because the early problem with they made components like that were just like sticking a big pipe down in the bone, and people had a lot of thigh pain because of the transition of stiffness at the end of the component.
And I have to imagine if you take an impact on some of the older ones that were more solid, this could just break the bone out.
It can, yeah. It doesn't as much anymore. I mean, this piece was made, you can see how it's tapered at the bottom.
Right.
That was to reduce that stiffness of the metal as it transitions to the end of the bone. Currently, I use this one, which is the most common stem geometry used in the world today. That shape is multiple manufacturers make it. It's the one that's a little easier to use when you're doing a direct anterior approach, which we talked about talking about. But it's the same. It's uncemmented. The bone's going to grow into it at the top.
Now, I'm looking at the top here, and I see some numbers written on here, and you probably know exactly what they mean. Looks like it says like 5 degrees, 40, and then 12, 14.
1214 is what's called a Morse taper. So
Okay.
it's slightly tapered because when you put this on there and hit it with a mallet, you can't get it off.
Right, it locks it in on that taper.
yeah.
Okay.
So you can see these are of the balls in are four different sizes. So when I started, this was a common size we would use.
Which is not very big at all.
It's not. It looks very tiny to me now. And this progressive gotten bigger, and the reason you can do a bigger head is the plastic has gotten better.
Okay.
So it's kind of a balance between stability and wear.
Now, I'm also looking at a difference here. I'm going to hold these up for the camera to see. So you've got what looks like very polished, almost a chrome type finish, to what it looks like it's a coated chrome. It's got like a pink material on it. Is that just something to help with wear?
Yeah, so the pink one is ceramic.
Oh, okay.
And that ceramic is felt to have better wear properties than the cobalt chrome is what that one is. I always feel a little guilty putting this in a male, but this is the only color it comes in.
Right. Deal with the pink. It's fine.
And when the early ceramic came out back when Jack Nicklaus, when he was younger, had his hip replaced, he had a ceramic hip. That was
Really?
But the early problem with the ceramic was it would squeak often.
So you could hear it in your body, or could people hear it outside?
People could hear it in the room.
Really?
I mean, it was loud. I've heard some patients through the years.
I mean, I've been told I creak when I move sometimes, but not quite like that.
This
Okay.
is very noticeable. But the new ceramic doesn't do that. I've never had a patient that mentioned that at all.
Now, I've noticed that there also seems to be, and I'm guessing it's because ceramic isn't quite as heavy, but I'm noticing that this smaller cobalt metal one feels heavier than the ceramic.
Yeah.
And I've noticed that the smaller, you said the more common insert that you put in is smaller and appears to be lighter. Is that just because the materials are better and stronger and don't need to be as big? Or we can just make them smaller?
Well, it's somewhat this. I think this one comes in these sizes. too.
Okay.
This just happens to be a smaller. This one is pretty small. So this is a 9, which more typically I'll put a 12, 14, 15 size. This is a smaller one that's in there. But the weight, the weight, it's really, weight doesn't, from my end of things, doesn't really matter as much as the wear properties. Honestly, the cobalt chrome works fine.
Right.
But ceramic is supposed to be a little better, so younger people, I will put the ceramic in for sure. Occasionally, if I have an older patient, I'll use the metal. It's a little cheaper. Cost is always an issue in the joint replacement world because anytime you get new technology, just assume it's going to cost more.
Right. Before I get into my next line of questions, as we're hitting the bottom of the hour, to remind everybody this is a paid program. Advice and opinions expressed during the program are that of SSM Health, not necessarily WBEV or Good Karma Brands. I wanted to ask, because we talked about when it came to knees, that sometimes people need a knee replacement, and then maybe 10 years down the road, they might have to get it, 10 might be the wrong number, but a few years down the road, they might have to get it re-replaced.
Right.
I'm assuming because there are parts here that are unfortunately going to wear down, that's a reality in hip replacement as well.
Yes, for sure.
What kind of timetable are we talking?
Well, the short answer that I would typically give to that is more than 80% of them should still be functioning 20 years after they're put in.
Okay.
But that's an old number. And so that's a number that was before this new plastic came out. It was a number before ceramic was commonly used. So
Gotcha.
I'm not sure. I think it's better than that.
So really, it's one of those things where, again, time will tell. People can say, well, this, we'll put it in car sense. Well, this motor will run for 400,000 miles. Well, until you've ran it for 400,000 miles, you don't know for sure.
Correct. Absolutely. Okay. That's inherent in orthopedics.
Let's talk a little bit about mobility. When I hear people talk about, getting hips replaced, obviously there's generally some work to get used to it. Do you lose any mobility? Like, do you find that you can't walk as much anymore? Or, like, are people getting this done and then able to get back to running if they were a runner, or take walks every night if that was something they loved to do?
There's a lot in that question.
Okay,
there. So
lay it on me. What do you got?
I would say it's not a normal hip. It's not a 25-year-old's hip.
Okay.
But you have to remember the reference is not comparing it to a 25-year-old hip. You have to compare it to the hip you had before you had it replaced. And typically an arthritic hip hurts to walk, and it has very poor motion because just like the knee, the hip will get stiff with motion. So as compared to that, the replaced hip typically has considerably more motion, and there's really no restriction on walking. I'm sure there are people who run after it. Probably not the best idea because of the wear issue. But it makes sense that's going to probably accelerate wear compared to biking, elliptical, walking. Is it going to? Are people able to do it? Yes. Yeah. I mean, it's possible.
Right.
It's just you make a choice. If you're 45 and for whatever reason you had your hip replaced and you want to go back to running, you're probably going to have a revision. If you live depends on how long you live.
Right.
If you're 65 and you're fit enough to run, it's probably not going to matter. It's probably, for one, that person probably is not heavy,
Right.
But I wouldn't say put running at the top of the list of goals after hip replacement. And most people don't. They're not at that place.
Right.
But
It's more
certainly,
of comfort of life mobility than it is.
absolutely. Walking, much as you want, no restriction at all. Biking, no restrictions. Hiking, those types of activities. I would say even cross country or downhill skiing, snowshoeing. I don't know that water skiing is as good an idea, not because of wear, but just because of the potential for dislocation. Just a traumatic fall or something. It's
Right.
a dislocation of the hip is traumatic at any time. Only made worse by being in the water, probably. But
Which actually, that ties me into something that I was meaning to ask when we were talking about knees and we were talking about cartilage in general. When I think of cartilage, even the cartilage we like to talk about on the end of chicken bones,
Yeah.
It is a little bit soft, a little bit malleable. But when I think about this cartilage replacement that you have here, this feels very stiff. So having that come out of socket, it doesn't lock in there.
correct.
Right? It just rests in there. But this isn't gonna flex. There isn't gonna have that quite the shock absorbing characteristics.
Correct.
So anything that you're gonna do, like water skiing, where maybe you're hitting that water pretty hard, you're gonna feel that a little bit more. Would be my thought, right?
Well, yes, potentially it'll transmit to the bone, but the issue is your leg getting into an awkward position and the ball coming out of the socket. That's what you don't. Let's fit in there. You don't want this coming out of here.
Right.
That's very distressing. Generally, it requires a trip to the ER and anesthesia to get it back in.
Oof.
You don't want that.
Yeah. Okay.
But yeah, it's not the same compressibility that normal joint cartilage is.
So we obviously don't have somebody here to do a mock hip replacement on, or to go through that process. So I'm going to ask you some questions about how it's done. Before we get into the questions of how it's done, I want to jump to past the surgery. How long are we talking after getting it done before you start to kind of get back to that normal life, where you got that, obviously there's a recovery time frame.
Right.
You may not, you probably can't use it the next day, maybe, I don't know. But what are we looking at?
Well, I think most places now, most surgeons will have patients get up on it the day of surgery. Weight bearing
Really?
is tolerated. Yeah.
Wow.
I mean, it is secure and tight when you put it in there. It's not going anywhere. For both of these, when we're putting the socket in and using the little cheese grater,
Right?
we go to, so this is a 54 millimeter diameter. I would use a 53 millimeter reamer, the cheese grater.
Right.
So when I'm putting it in there, it's a millimeter bigger than the hole I made.
Okay.
And so it's tight. So that's not going anywhere. And plus I put a screw in there. Same with these. When you put these down, it's a tight fit. It is
Right.
slightly bigger than the hole you create. So you're putting it down, and it's kind of a wedge. So once I get it down in the bone, I can't pull it out. You have to use specialized tools to get them out
Right.
if you want to take it out for some reason.
And does it take a while for, I mean, I imagine it takes a while for the bone to kind of start to heal into and really grip onto that further. But, I mean, I'm guessing it's not a different growth speed than what you'd expect from somebody healing a broken bone.
Correct. Exactly the same. So I think 6 to 8 weeks. But they've kind of progressed to the point where we used to, if we put it in without cement, we would have people on crutches for that, or walker.
Right.
We don't do that anymore. It has been shown not to make any difference. So you get up right away. But back to your question as far as recovery. So I think sometimes it depends on how you define recovery, for one. So from a work standpoint, for most people that do anything that's remotely physical, I will tell the workplace 3 months, kind of like with knees. Give yourself plenty of time to heal. But you are progressively getting better during that time. As good as you ever get to where you can do everything you want to do, I mean, it's probably a year and a half, afterwards to gain your strength back and get some flexibility back.
Now let's talk about the process of putting these in, because I mean the hip is, in my brain, it's not a small area you're having to work with, and depending on the individual, I mean, I've known some people who I don't know if this is the right term to use, but they're very hippie. They're very wide in the hips.
Yeah.
And so you got more material. I'm sure you got to work through to get there. Like, how do you do this?
So that's kind of been one of the areas of orthopedics that there's been a lot of work in during my career. So most people in my era learn to do hip replacement through what is called a posterior approach.
Okay.
So the incision is on the side, kind of tailing to the back, and posterior is the back of us.
Right.
And so you go into the hip joint from the back.
Okay.
So that's still the 40% of hips in the U.S. are done through the posterior approach. I should preface all of this comment about that there is no evidence that there is any long-term difference between the three types of approaches I'm going to tell you. So there's people that do posterior approach and do it well, works fine. What you want to do is you want your surgeon to do the approach he's comfortable doing.
Right.
So you don't want to go to a guy who always does it posterior and say, I want you to do it anterior, because we're not as good. There's subtlety to it, and you get better. Right. So 40% of the hips do a posterior approach. That's the way I learned it, and I did it that way until about 2011. And it works fine. The problem I had with that is that it's a little more prone to dislocation. And if you look at these two plastic pieces, you can see one of them has a little lip on it.
Right.
So I would use that, and you put that in the back because that's the way the hip would come out, because that's how you're coming into the hip. So the tissue is we would try to repair it after surgery, but there was, when we put the implants in and we're checking the stability of the leg and moving it around, there was always a position where I could rotate the leg and then the hip would come out. And then it was a decision in the operating room, well, the patient's not going to get into that position. And most of the time, that was the case.
Right.
But it's a distressing complication because patients hate it. They have to go to the ER. It's painful, and it tends to continue to happen when it does happen once.
Right.
So in that era, when I switched, I had a partner who did it through what's called a direct lateral approach.
Okay.
And I learned to do it with him. He showed me how to do it. And so in that approach, your scar is still on the side, but it's more straight.
Okay.
And you come down to the hip, and then you go into the hip from the front, the anterior side, not the back. And so all that tissue in back is preserved. And so now when I get to that point where I'm checking stability, I can push the leg as far as it will go, but either direction, and it doesn't come out. So I'm not at all worried about stability now. But like everything, all the techniques have pros and cons.
Right.
This approach, you have to take some of the muscles off the side that raise your leg out to the side. And so after surgery, you need to really work hard to recover that strength, and that takes some time to do that.
Now, are we talking a considerable size incision and considerable? Because I mean, you're having to get in there with, again, we're going to use the term cheese grater here, but you got to get in there with some power tools. I mean, you're talking about, obviously you have to make the cavity that allows you to, or make the start of the cavity that allows you to insert the insert into the top of the femur, and be able to, to hammer that home. You got to have some space, right?
Well, that's changed too. And so when I started orthopedics, it seemed like we made an enormous incision.
Right.
And now, it's most of them are 4, 5, 6 inches at most.
Wow.
And there was a big push for the minimally invasive,
Right.
which was more marketing, but it was a time where we could realize, we don't need as much incision. I mean, it's the better we can see, the better. But the minimally invasive, the skin incision isn't the problem with joint replacement.
Right.
And so if you don't put it in well because you can't see as well, that doesn't do the patient any good.
Right.
But I think everybody has reduced the size of their incision. So it's not a it depends on the size of the patient, honestly.
Right. Well, and in the grand scheme of things, you got to at least make an incision large enough to fit in the pieces.
Right.
Right.
But
I mean, the skin's a little elastic, but
you only need a hole that big to get, that's so
right.
it can be done through a small incision. I can't. I like to be able to see things a little better. So the direct lateral is about 20% of joint replacements.
Okay.
The other type, and the newest type that people may be hearing about, is called direct anterior. Direct anterior is different because the incision is on the front.
Okay.
And you go down straight down into the hip from the front side. And the people that do it would say the advantage is earlier recovery.
Okay.
I would push back on that a little bit. I don't think there's a lot of difference with that, and there's no long-term difference. But it for me, and I have done that, and I've been through the training a couple times, and honestly, I did it, and it didn't go well. And I just thought, there's no long-term difference. The technique I use, I'm very comfortable doing. If people want that direct anterior, there are people in the area who do it, and as their primary approach. And so I just decided I want to go back to the direct lateral,
right.
because I think it's consistent. I can do that well. And so, between the three, there's no long-term difference. So.
I'm trying to think of, the reasoning why, as an individual, if I'm thinking about my hip needs to be replaced, I'm in pain when I move and I walk and I bend, and I can't sleep on that side. I can't not sleep on that side. It just, no matter what I do, it hurts. I guess my thought process isn't, where's the scar going to go? It's more of how quickly can you get in there and fix it?
Right.
Which I guess leads me to my next question. What's the wait time on getting something like this done?
Well, it varies, I'm sure, by surgeon. But when we're talking hip replacement, not too many people are showing that scar around to the public, anyways. But maybe for some, maybe that's a consideration. But
you haven't seen the bikinis I wear. What can I say, Bert?
Kudos to you for the self-confidence. Thank you. It depends. I mean, it is. We're all dealing with this surge of patients. So for me, we're scheduling in 2025 now. Okay. But that's a new 3-4 months out.
Right.
That's never been that way until this year.
Wow.
So it varies by where you go, I'm sure, but I think everybody is getting busier because there are more people that. So it's not something that you want to get to the point where you need it done right now and call up and think it's going to be done next week, because it just won't happen that way. No one's going to have it. Plus, you need medical clearance before,
right.
And there's some process to it.
I want to talk to you about, because when I think about any time you do any replacement in the body, hip, knee, shoulder, whatever, I mean, anytime you're doing surgery to the body, you're cutting into the body. There's always that aftercare and the pain you're dealing with after the fact as you're getting used to things, or as your body's healing. We know how long you said before you can be putting some weight on it, and for that kind of healing, but should people expect any discomfort or pain? How long should that last?
Yes, I mean, certainly there's going to be some pain, but it just seems like the pain experience is better than it used to be. But most people, for a couple of weeks, use we use hydrocodone. Used to be Vicodin, Norco. It's a narcotic. You can use ibuprofen with that, but most people don't don't need it more than a couple of weeks, and they transition to the ibuprofen and Tylenol or a combination. So it's not. I mean, I think for most people, it's present but tolerable.
Let's talk a little bit about the future of hip replacements. I'm kind of a technology dork. Like I've got a 3D printer at home. I used to be part of a group that would crowdsource parts to make 3D printed replacement limbs for people who couldn't afford it. So like my job might be to make the cover that goes right here on the arm or whatever, and we'd send off somebody who would assemble it and deliver it. And I know I always hear about like, oh, well, we can 3D print better lattices for the bone to grow into, or we can do that. And I see, the lattice work on here, and obviously there's some thought process that goes into how this mesh works. What are we seeing for like new technology coming out besides ceramic balls and cementless inserts?
In the hip, there is probably the biggest thing is there is some work with robotics, which the knee is ahead of the hip in that regard in widespread use. Just trying to get the position of the implants proper and the length right. That's I think probably the biggest push in hip replacement.
You almost made me excited when you said robotics. It was like robotic hips. Like, can it walk for me? Yeah. But no, not quite yet.
Not yet. No, that's looking for that Michael Jordan hip, but we don't have it yet. But.
Right, we're working on it. People, stand by. Is there any question that I should be asking that I haven't when it comes to hip replacement, to joint replacement in general? Is there a question that people should be asking themselves that maybe I haven't brought up forward here?
Well, at this point in my career, I think the thing that I'm most focused on is preparation of the patient for the replacement to optimize their outcome.
Yeah.
And you want to have a good outcome functionally, and you want to avoid complications.
Right.
And there are things that we can do ahead of time to prepare. And if you're a diabetic, you can't suddenly become not a diabetic, but you can be a well-controlled diabetic. You can improve your all of us, I think, can improve our nutrition, which impacts greatly our immune function. Immune function helps deter and reduce the risk of infection, because prosthetic joint infection, hip, knee, shoulder, wherever it is a disaster. Your life is never the same. It is to be avoided at all costs. And so I think should be a real emphasis on preparing ourselves medically leading up to it. The other thing is just physically, and that's a little more of a challenge because we hurt. And people that are saying they need a hip replacement aren't doing a lot of exercise because it hurts so much.
Right.
So to me, it's kind of like a professional athlete going into a season having done no training in the off season. They're going to struggle.
Right.
And so if there's a way to do some activity, and so we will get physical therapy involved and trying to get people to do some sort of strength training, flexibility if they can, just in preparation for this index event of surgery.
Right. That makes a lot of sense. And it's, with they say an object in motion stays in motion, better to use it than lose it, stuff like that.
No question. That's our human existence for sure.
Yeah, absolutely.
You get one shot. Your first shot is the best chance you have to make it as good as possible. Every time you have to redo joint replacement, it doesn't work as well.
I imagine, yeah, because the work, you talk about how well the bone holds on to these pieces, and even after just the initial insertion, I imagine getting them out after they've been in for 15 years is a bit of work and a bit destructive.
It is. But usually you're in there because they have loosened. Something has happened, and so, but you lose bone, so you have less bone to work with when you're going back in there. Okay. You've taken some away, and there are different. I don't have those instruments,
right.
but there are more involved replacements to make up for those deficiencies. But anytime just operating in the same area second and third time, the tissue is just not normal again.
That makes a lot of sense. I've learned a lot here, Dr. Burt, and I always love when you bring in the stuff for me to look at here. I'm a very visual guy, and hopefully our viewers on Daily Dodge TV were able to get a a sense of this, if you were only listening on the radio, you really did miss out on half of the cool stuff that you could have possibly taken part of here. But my goodness, thank you again. We want to welcome anybody who has questions about this, anybody who wants to know a little bit more about everything orthopedic care and the stuff that they can do even before they get to this point, obviously, because there are preventative things you can do and ways that you can take care of yourself to hopefully delay this as long as possible. Of course, I can reach out to you, 920-324-6802 or 920-887-6650. Find you guys here in Beaver Dam and Waupun. Any final words for our listeners?
No, if you have hip pain or knee pain or questions, give us a call. We can at least answer your question. Doesn't mean you're going to need a joint replacement, but we can hopefully solve the problem.
And you'll know better than most if joint replacements in the future, right?
Yeah. Hopefully just give you more information and then let you decide.
Better to be well informed than not.
Correct.
Dr. Burt, I thank you for coming on. Once again, Dr. Burt Callahan. I am Justin Ninja Wilski. This is Taking Care of Business. The proceeding was a paid program. The advice and opinions expressed on the program are solely that of SSM Health, not necessarily WBEV or Good Karma Brands.